Implementation of newborn hearing screening. The advocacy was given by JCLH way back in 1970s. It consists of three organizations: American Academy of Otolaryngology, American Academy of Pediatrics, and American Speech and Hearing Association. The initial screening utilized high-risk register-based screening. That is, they developed a checklist wherein any child who was born with any of these risk factors were taken up for detailed evaluation. The problem with these high-risk factors is it is not mandatory that only children who have high-risk factors should have hearing loss. Also, it doesn't mean children who don't have high-risk factors will not have hearing loss. So, because of these two reasons, the high-risk-based studies were not so popular. In 1982, they gave a historical statement where infant at risk were suggested to be screened using electrophysiological method rather than using any behavioral method. In the behavioral method, they used to use sound makers and see the behavioral responses, but that was not objective enough to quantify whether the child actually had hearing loss or not. Only by 1982, when ABR was most prevalent, they suggested identify the child using HRR and then subject the child for detailed electrophysiological evaluation. In this regard, ABR was the first test that was suggested by the JCIH. So it evaluates the status of auditory nerve up to the level of lower brainstem, to be precise to the level of inferior colliculus. And it was recommended to be administered on all children who were at risk of developing hearing loss. That was identified using the HRR that was developed. So ABR is recorded by placing the electrodes on the scalp, and the responses to a sound that is click usually we use is going to be recorded by the electrode that is going to be placed. A series of waveforms can be obtained from different levels of the auditory pathway. So here we can see we get responses from the auditory nerve. See, first peak that we are going to see is from the auditory nerve, then from the cochlear nucleus, followed by inferior colliculus and lateral lemniscus. So these are the series of peaks that were obtained that can be observed in a normal hearing adult or infant. Usually the fifth peak is the one that we are going to be considered for diagnostic purposes, but all other peaks will also have other implications. But presence of fifth peak is more than enough for us to say that the child's hearing abilities are going to be normal. In 1994, again, second technology was introduced with ABR, that was photoacoustic emissions. So this photoacoustic emissions, this was a breakthrough because doing ABR on all high-risk children, at least doing one ABR even on a normal child, preparation time as well as the time taken to complete the testing takes 1 hour. Whereas OEs can be administered because it does not require any preparation time, it can be completed in 10 minutes, both the years together. Hence, in 1994, the definition of UNHS, that is Universal Newborn Hearing Screening, was introduced. Before 94, it was only HRR based. Only children who had high risk were taken up for para-evaluation. Whereas 94 onwards, all children born in a particular hospital were enrolled for newborn hearing screening using OEs. So let's see what are OEs. OEs are photoacoustic emission sounds that are generated by the outer hair cells in response to a sound. So OEs are not just the activity of the outer hair cells that are measured, it also reflects how well the outer hair cells are working. If the outer hair cells are not working, the photoacoustic emissions will be affected. The presence of photoacoustic emissions also indicates that the middle ear is also fine. What does the presence or absence indicate? The presence indicates that there is no significant conductive hearing loss, so there will be no need of doing bone condition testing also. And threshold sensitivity is better than 35 dB range. OE sensitivity, OE will be present even in individuals who have minimal to mild hearing loss. But when the hearing loss exceeds 40 decibels, then OEs are going to be affected. The OEs can be absent even in the presence of conductive component as well as when the inner ear outer hair cell damages. So if we compare photoacoustic emissions with ABR with respect to some of the aspects, we can see that the preparation time for OE is minimal as compared to the ABR is going to be slightly higher. Test time under ideal condition, it can be completed once a week for a normal hearing child can be completed in 1 minute. But as AABR along with documentation under the text will take 20 minutes. So here AABR means automatic ABR, where we are going to present the stimulus only at one particular intensity and we are going to record the peaks. The peaks are present at that particular intensity, then we consider the child to have passed. The referral rates are high for OEs because even if the conductive loss is present, OEs are going to be absent, whereas ABRs are slightly redundant for the presence of conductive pathology. Effect of environmental noise. OEs cannot be done in open environment. It requires a sound treated environment because the presence of external noise is going to affect the signal to noise ratio, or if the noise level is high, the OEs might be absent even in a child who has normal outer hair cell function. Whereas AABR does not require any specialized environment as such. OEs measure the function only of the outer hair cells, but we have to make sure that the external and middle ear status is fine. Then only OEs absent can be considered as presence of outer hair cell dysfunction. AABR measures all the way from external ear up to the level of lower brainstem. The frequencies that are commonly tested in OEs are 500 to 5000, whereas AABR is slightly restricted because we use only one stimulus, that is broadband clicks. How accurate is it? The false negatives, again OEs cannot identify auditory neuropathy because presence of OEs does we interpret as outer head cell functioning, but pathologies beyond the outer head cell functioning cannot be identified by using OEs. Next, AABR, it also might miss high frequency or reverse looping hearing losses. Now in 2000, they gave the definition of EHDI. It is the first time when they did not restrict themselves to identifying the hearing loss. They went one step ahead and started with the concept of early intervention. So screening has to be completed by 3 weeks, confirmation of diagnosis has to be done by 3 months, and early intervention, that will be starting of hearing aid fitting and other things, should be started by 6 months. So this was the concept that they gave in 2000. In 2007, they added 2-step procedures where either you can follow 1-step OE or 2-stage AABR plus OEs. This is how it is going to be implemented. This is the first stage where screening is going to be taken up. If a child passes OE or AABR screening, then all this information will be provided and the child might be released. If the child is referred, then it will be sent for second stage outpatient based screening. This would be done in a new before the discharge of the child. In the second stage, if the child is referred, then the child is going to be sent for detailed evaluation. If the child is passed from the screening even in the second stage, then also the normal developmental milestone and other information will be provided. The child will not be asked for follow-up. In detailed audiological evaluation, ENT evaluation, mid-ear analysis, photoacoustic emissions, APR and other testing will be done. If a child is suspected to be having hearing loss, then whatever is the hearing aid fitting and other options, that will be provided to the child. Here we are giving a timeline. In 3 to 6 months, this diagnostic evaluation as well as intervention should start, whereas child's diagnosis should be completed within 1 to 3 months. Now, what is the disadvantage of using this protocol that has been given by JCIH? First, use of OEs, because they have suggested either you use only OEs or you use OE plus AABR. If we use only OEs, absence of OEs does not necessarily mean that it is a case of outer hair cell dysfunction. It can also be due to middle ear pathology also. Presence of OE not necessarily mean the child has normal outer hair cell activity. It could be a case of auditory neuropathy also. And also issues related to the recording in the presence of noise is a big problem. And including AABR for screening, average time to screen a child is going to be high. The equipment is expensive, recurring expenditure and careful maintenance is required. Even an artifact, the electrical wiring is not fine in an environment, ABR cannot be recorded. The screening cost is also going to be high. If we try to implement this even to an Indian context, there will be 3 issues that we have to focus on. If we are applying to a hospital where the number of birds are high, it is not practically possible for us to do OE as well as AABR. But also the age at screening that we are seeing here is around 4 to 4.6 years. Most of the parents does not turn up well before the age of 4 years. So hence the concept of UNHS is scanty, so it is very difficult. The number of trained audiologists who can do an AABR and identify it accurately is less. Hence the number of hospitals which have taken up the UNHS is also. So now we had 3 problems that were associated. So looking for the solution, we had to have a method using which all the disadvantages which were listed were overcome. So while we were looking for a solution, we came across 3 tests which were combined by Berlin and called collectively as Triage Trio. This includes emittance in the test battery and does not require an APR to be involved into this battery. Emittance, as we all know, it is a test for mid-year analysis where we are going to give vary the pressure and keep some amount of sound. How much amount of sound is going to be reflected back or going in will decide whether an individual has middle ear problem or not. So emittance does not include only one test, it includes two tests. One is the tympanometry that assesses the middle ear status, and second one is the reflexometry that assesses the hearing status similar to our auditory brainstem response. Auditory brainstem response measured from auditory nerve till the inferior colliculus, whereas acoustic reflexes, they measure up to the level of superior olivary complex. So hence to one level lower, but still we'll get enough information with reflexes also. Hence the combination of tympanometry, OE and ART can be utilized, and it can substitute the conventional OE plus AAVR protocol. So the advantage, how well we can utilize this concept. This is the highlight how well we can use this, irrespective of the type of hearing loss that we are going to encounter. We can identify most of them, or we can suspect most of it. For example, if we have to make sure that the tip is normal in all the conditions. If it is abnormal, then it has to be ruled out because it leads to a diagnosis of conductive hearing loss. If the tympanometry gives normal mid-ear functioning results, reflexes are present and OEs are present, then we can say normal mid-ear functioning as well as normal hearing sensitivity. If the reflexes are present or elevated, whereas the OEs are absent, that indicates the hearing loss. Outer ear cells will have a hearing loss up to 50 decibels. So if the hearing loss is greater than 50 dB, still we can record the reflexes. So we can conclude that there is a cochlear hearing loss which could be somewhere close to 60 dB range. If the tips are normal, reflexes are absent, whereas OEs are present, this is a cardinal sign of auditory neuropathy spectrum disorder. So just by using OEs or AAVR, we could not have suspected auditory neuropathy, but just by using OEs and reflexes, we can still suspect auditory neuropathy. Now, if both reflexes and OEs are absent, then we can suspect the degree of hearing loss is greater than 70 dB. If the tips are normal, then any of these things are possible, so we have to make sure that the tips are reflexes are absent because the pathology is going to be beyond the inner hair cell in the auditory nerve. Okay, the lesion, site of lesion in auditory neuropathy is inner hair cell, the synaptic junction of inner hair cell and auditory nerve, or in the auditory nerve. The reflex pathway sends information from the auditory nerve to the superior olivary complex. Again, it comes back to the middle ear through the efferent nerve. So since that pathway is affected, we will not get reflexes in this. Outer hair cells are not affected in case of auditory neuropathy. So we used this protocol and we conducted a large-scale study. In 2016, we published this in Journal of Phonetics and Audiology. Here we can see, rather than using individual tests such as tympanometry, OEs and so on, we obtained a combined physiological test sensitivity of 96% with a specificity of 99%. There was a huge reduction in false positive and false negative. If we had used a single test, you can see TOE itself can have a false negative results of 9%. So that was greatly reduced by using combination of these things. So this is what we are following now to make sure that none of the child who has errors on screening will miss. Either we do not miss a child who has normal hearings, neither we are going to identify a child who has hearing loss. This approach helps to diagnose the site of lesion as compared to OE or AAVR based approach. Hence the concept of early identification and intervention will be possible.